The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
Before we get started, I'll introduce our sleep expert. Dr. Kennneth Sassower is a pediatric neurologist in Boston, Massachusetts, and is affiliated with multiple hospitals in the area, including Massachusetts General Hospital and Newton Wellesley Hospital. Dr. Sassower received his medical degree from Universidad Autónoma de Guadalajara and has been in practice for 33 years. He is one of 231 doctors at Mass General and one of 22 at Newton Wellesley Hospital who specialize in neurology. These webinars are made possible through generous donor support. If you'd like to contribute, please visit our website at autism.com. And now I'm going to turn it over to Dr. Sassower.
Well, thank you very much. I appreciate it, Ms. Fulton, and it's a pleasure to be here. And the way I understand it, I will be taking any questions and answers that folks want to ask. So feel free to fire away, and I'll try to do the best I can.
Okay, great. Well, we've got a lot of questions, as you can imagine.
That's great. That's great. I just want to add one more thing, just as a backdrop, so that the folks in the audience know. So I'm a pediatric neurologist, as you have mentioned, and I had done my pediatric training over in Downstate Medical Center in Brooklyn. I did my neurology training at Mount Sinai Medical Center in New York City, and then I did epilepsy training over at the Miami Children's Hospital. I did a fellowship training there for a couple of years, and then I subsequently did a sleep training for several years over at the Massachusetts General Hospital in the early 90s, and I just stayed on there. So I've been over at, as you mentioned, I've been over at the Mass General Hospital, where I'm primarily based for the last roughly about last two and a half decades.
Great. Thanks for that. Thanks for explaining more about it. I know a lot of the people on the line are dealing with different issues, neurological issues like seizures or epilepsy and comorbidities along with autism. So it's so helpful to have all that expertise on our call today. So I will jump right in. We have so many questions, but the first one is from a parent who is asking about their 5-year-old son. This parent says, "My son has been a wonderful 12-hour a night sleeper. His bedtime has not ever changed from 7:30 p.m. since he was 3, but now he wakes up earlier. He's still ready for bed at 7:30, but he's getting up 6:30 to 7:30. He is very strict with his schedule. Recently, he has been restless and leaving his room to sit up with us. He will turn off the light, but want to watch TV with us after 30 minutes in his room. I need to bring him back to bed and lie down with him to calm him. This will repeat numerous times. So how can we get out of this cycle of me needing to help him get back to sleep? Do you have any advice? Could this be a medical issue? What does this sound like to you?"
Well, thank you for that question. I think that it's just in a general sense. It's hard to know in terms of why someone who has really demonstrates consistent times of going to bed all of a sudden will wake up earlier and have trouble getting back to sleep. It sounds from the question that this is a relatively new issue. So it sounds like the child was able to sleep through the night. It was my understanding, and so. But as the caller mentioned, it might be due to it's described as being, the child is described as being restless, and sometimes we do see that. We do see motor restlessness that's occurring in the middle of the night, for which it's hard for this particular subpopulation, because I think it has to do with the fact that children are often either pre-verbal or non-verbal, and they can't really express as to what's going on. And so we always wonder about that. And just to the larger question, could this be a medical issue? We always default to that position, because we have to say to ourselves, if it's different if someone can tell us what's going on. But when folks have difficulty in saying what's really going on, then we have to sort of almost consider medical possibilities as well. And some of the medical possibilities could be things like restless legs syndrome, where children often feel restless or antsy about going back to sleep, and that often has to do with some neurochemicals in the brain, some neurotransmitter issues, including dopamine, and so sometimes that is a beneficial. We sometimes give, and that process is mediated by iron. So sometimes we look to see, well, is the child iron deficient, and if so, we may try to increase iron either in the diet or by supplements. Or sometimes we even have to try and treat it with some medications that help with dopamine neurotransmission. There are other causes as well. It may be that this is just a lot of times sleep issues are a function. We sleep tonight like we slept, in a sense, like the night before. We're almost, in a way, almost programmed, in a sense. And so sometimes children just wake up for reasons, they just wake up for a couple of nights in a row, just like we all have. And we have sort of bad night's sleep, and then it's sort of bad sleep begets bad sleep. So for that, there may be we sometimes use behavioral techniques and try to, and I'm sure the folks in the audience know it better than anyone. In other words, they try to sort of, if the child is all of a sudden staying sleeping with the parents, and it might be something where we try to sort of what we call graded extinction or gradual extinction, where we try to sort of over time try to modify that behavior such that the child's able to return to his or her bed over a period of time, but if there's but we always, like I say, we always default to the medical issue. We want to make sure there's nothing going on medically that's impacting. Other things that could possibly be impacting in particularly in kids on the spectrum are pain states. Sometimes for reasons unknown, children on the spectrum are often prone to reflux and gastroesophageal problems, acid reflux and reflux esophagitis, and sometimes it's a pain state, and and they can't get back to sleep because they're truly in pain, and that often happens in the middle of the night, even in children who don't necessarily complain about issues during the daytime. So sometimes we have to look for the medical issue as well. But so it's hard to know on first blush, but I think we have to think of both behavioral issues as well as medical issues in terms of what's at play here. And sometimes if it's so chronic over a period of time where children wake up over the course of the night and have a hard time getting back to sleep, sometimes we just don't know, and we sometimes that might be an indication for doing an in-lab study or with EEG monitoring, just to make sure that, just to try to figure out what's going on. Why is the child waking up at this time? Is it related to, for example, a certain stage of sleep like REM sleep or deep sleep? And if so, is there something that we can do about it to help return the child back to a more normal sleep pattern?
Okay, so you mentioned sleep studies. A question another parent had was about the use of pulse oximetry, just sort of as a gauge of whether a sleep study might be warranted. So this particular individual's child is having lots of desaturations during the night, so they're concerned about sleep apnea. She wants to know about the validity of pulse ox as an assessment tool and whether or not that would warrant a referral to an ENT.
I think that's a great question. I think pulse oximetry is a wonderful tool that folks can use at home, and it can assess whether or not children are having frequent and recurrent oxygen desaturations. And it's essentially, it can be a very, very good tool. It sort of depends on the pulse oximeter, but by and large, they are, I look for not necessarily absolute values. sometimes the pulse oximeter can be fraught with some difficulties with respect to recording. Sometimes if it's actually put on, the pulse oximeter is often put on a finger, and it's sort of it's stuck like almost like the movie E.T. You know, it has that quality where it's actually almost like put on as a finger probe, and sometimes the connections are not well adherent, and so sometimes oxygen levels will falsely be lower than they should be. But as a general trend, I think, and presuming that it's well on the child's finger, it can be a helpful test, particularly in trying to screen a child for sleep apnea. And the best way I try to gauge that is the child having intermittent fluctuations in oxygen desaturations throughout the night. Usually we will see these changes are occurring in a periodic or cyclic fashion, for example, every couple of hours. And the reason why that is because that may be tied into REM sleep. And during REM sleep, children who have sleep apnea are more prone to drop their oxygen saturations. And so it's a reasonable thing to have a monitor of that type just to screen as a general rule of thumb. There are some children who have, low oxygen saturations throughout the course of the night, and that might suggest some interstitial lung disease or some problem, but that's less common. What is more common is that children are doing well and their oxygen saturations are well for most of the night, and then as they progress through various stages of deep sleep, the oxygen saturations will then decrease and they will diminish, and that may be a harbinger or a suggestion of sleep apnea. And so it's a good pre-screening tool.
Okay, great. This next question, I think this person's asking this because of your background with epilepsy. She says, my daughter is 13 and has high-functioning autism and epilepsy. She sleeps 10 hours every night and requires a 2-hour nap every day. If she does not get this nap, she becomes ill. Could this be seizure activity at night? Is this something to do with the autism? Why would a nap be required at this age?
That's a great question, and I think we even in 2016 we're trying to understand the relative role of seizures and abnormal EEG discharges on sleep functioning. And even though it is known that approximately 20% of all seizures in children are activated in sleep, we still don't know the specific details as to why that occurs and what does that say. What is the role of both seizures and what we refer to as spike or sharp wave discharges on sleep functioning? And so it's a good question. I think a lot of times what I find in children who have what we refer to as sleep-related epilepsy, and when I say sleep-related epilepsy, I mean that what's happening is that some children only have seizures at nighttime. Some children only have seizures when they're sleep deprived. So in other words, potential precipitant or provocateur for seizures are the fact that the child is not having a good night's sleep, and that's often what we see in terms of my clinic population. We see folks coming in where the children have seizure disorder, and it can be stable, but then it gets kicked off when sleep is awry, and so it may be. And I've always wondered about, it's been my experience that children who have sleep-related seizures, and when I say sleep-related seizures, it doesn't mean that the seizures only occur at night, but they occur in the context of either relative sleep deprivation or being too drowsy or being too tired. So they can occur during the daytime as well, but they're occurring because the child is more sleepy than usual. And so I think that one of the questions I always try to find out, I always ask parents, is your child who has our seizures, are they more hard to wake up than, for example, if they have other children than the other children. Often that's the case. Children with sleep-related seizures are harder to wake up as a general rule, and they require more naps. And so we don't know the exact why or wherefore, but there is a suggestion that perhaps at least having some children, for example, on the spectrum, have lots of spike wave discharges during sleep, and we know, for example, in the more severe cases where some children have continuous spike wave discharges during their sleep pattern at night, they're way more sleepier than other children, and they require naps. And so, and sometimes by helping that, by treating that particular aspect, the presence of these spike wave discharges during sleep at night, we can improve not only their sleep, but their daytime behavior, their ability to become more alert and attentive, and better able to concentrate during the daytime. So it's sort of a win-win situation, and it's only recently where we sort of became aware of this, that helping, the sleep aspect can sometimes, and particularly these sleep-related discharges, can actually help improve daytime functioning.
Sure, that definitely makes sense. I mean, getting all of that under control so that we can be more functional during the day. We all feel like that. I'm getting quite a few questions about melatonin. So I'll try to break these apart into a couple different topics. So one question is sort of a general question about how do you know if it's okay to use melatonin with your child? Do you need to work with a physician? It's available over the counter. How would you figure out dosage? So people are asking a lot of questions like that about how. So what are your recommendations when it comes to administering melatonin?
That's a great question. The whole subject of melatonin is a fascinating one. It's we've known for years. So just to back up, melatonin has two major effects. First of all, melatonin is made by a very small gland in the middle of our brain. It's a pineal gland, and the pineal gland is really the only sole function of it is to elaborate melatonin, and it does that in darkness. So it's very sensitive to what we call the light-dark cycle. It's really made in its most robust fashion when it becomes dark. And so the question became, over the years, people have said, well, if I take exogenous, or taking it, meaning to say taking it by mouth, can I, in a sense, trick the brain into thinking it's sleep time? And by and large, that seems to work. The two major functions of melatonin are really, one is as a soporific, meaning to say it induces sleep, and it does that in a modest way. There are probably other sleep medications that do it as well, if not better. But the real benefit from melatonin is, and this is true of both children on the spectrum or not, is the fact that it helps with children who have some degree of circadian or sleep clock issues. And so that's really the major role where I use melatonin. If, for example, somebody might say, well, I'm using melatonin because my child has a hard time getting to sleep. That's fine, and that makes sense. But it's particularly helpful if the reason why the child's not getting to sleep is due to a sleep clock issue, meaning to say that they're have more of a night owl kind of character. And all of us have that. I mean, some folks are better off. We get a second wind at nighttime, and some people you can't get to bed or at a reasonable, at an earlier time. Some people are what we refer to. So in the sleep literature, we refer to children as being night owls or morning larks, meaning to say, and that's actually, we see most children seem to fall into one of those two categories. And so really the benefit of melatonin are for children who have what we refer to as a delayed sleep phase, meaning to say that their real issue, the reason why they can't sleep at night, is because their whole sleep clock is shifted. And so what we do is, by taking melatonin, and in addition, there's some behavioral things we can do to actually, what we refer to as advance the sleep clock, meaning bring it in earlier, that's when melatonin has its greatest role. And so, in that context, so I use it particularly for children who have early, what we refer to as early insomnia or difficulties in getting to sleep, but they have it to a presumptive difficulty in sleep clock, where they're have a more night owl. And you might say, well, how do I know if my child's a night owl? And it's often in the sense that the children often, it's very common in the autism spectrum where children just, it's 7 o'clock, 8 o'clock, 9 o'clock. The child has no interest in sleeping. It's almost as if it was 3 o'clock in the afternoon. There is just absolutely no desire to get to sleep, or even not even the slightest yawn. And things are pushed back until later or early, I should say earlier in the morning. And sometimes some children don't get to sleep until 11 o'clock, 12, 1 o'clock, 2 o'clock, or even later. So I think melatonin has a role in that particular context for children who have some form of sleep clock issue where they can't get to sleep. When I say that, so I use that mostly for children to get to sleep. For children who have, like the previous caller who has said, my child sleeps fine at nighttime but then wakes up and has a hard time to get back to sleep, I think melatonin has less of a role in that context because it's really meant as a frontline agent to get children to sleep. So that's an important distinction. And then in terms of dosages, the pineal gland, which is that small gland in the middle of the brain that makes melatonin, is really makes less than 1 milligram of melatonin. And you might say, well, gee, my child's on way more than that. And it's true that a lot of proprietary formulas and commercial formulas have melatonin given at usually 3 milligrams, sometimes 5 milligrams, sometimes 10 milligrams. And I will say in the study of children on the spectrum, the dosages of melatonin are range from anywhere from 1 milligram to up to 10 milligrams, and sometimes even higher. I think in that context, we're using more for its, the soporific sleep-inducing effect than we are for advancing the sleep clock. So that it's okay to use it, and it's certainly been studied as one of the over-the-counter medications that have been studied in children on the spectrum more than any other agent. So it certainly has been looked at, but it's in terms of how much melatonin you need. It's not necessarily that more melatonin will get children to sleep earlier. It sometimes is the case, but it's so it's hard to make a hard and fast rule. So I like the idea of melatonin in the context of children who can't get to sleep due to sleep clock issues, and I think the dosages are variable, and they've certainly been studied from anywhere between 1 milligram to 10 milligrams.
Okay, and so they are asking about extended release, so they have these formulas where they sort of slow release throughout the night. Would that address the issue you're talking about, sleep induction, or is that a different issue,
Right.
The way sleep works?
That's a great question. Some people use extended release melatonin. There have been some studies that have looked at melatonin extended release and shown that children on the spectrum that their sleep has been improved with that. Once again, it's getting away from its use as a sleep clock medication. So in a way, if a child is sleeping, they're sleeping. But I tend to use more. I don't use that much extended release or sustained release melatonin in my practice because, for the reason I was saying earlier, it's really melatonin is designed to get children to sleep initially. For difficulty in getting back to sleep, I usually look at other issues and other agents if need be. So I'm not a big believer in sustained release or extended release, although there is literature to suggest that it has been helpful for a subset of children.
Okay, got it. Yeah, and the last question in that thread, what about somebody who appears to be completely resistant to it? So you're giving them melatonin and it seems to have absolutely no effect. Where might they go for more information, or is there something you'd point to if you had a family in that situation?
Yeah, I think that's a great question. If you're adding more and more melatonin and there's still no benefit, then yeah, I think you have to step back and say, hey, two things. One is to say, is the child's sleep any better by virtue of being on melatonin? And some families of mine will say, I'm not even so sure, and in which case I then bag the melatonin in its entirety and try something else. Now the question you might say, well, what are the something else? And that's a long discussion, but there are certain other agents that that have been used and to help children get to sleep, and they vary. And like I say, most of the literature has looked at melatonin because there has been some studies to suggest that metabolism of melatonin may be impacted for a subset of children on the spectrum. Not for all children by any means, and it's not entirely clear if that's the prime driver of sleep problems. I work at the Autism Research Institute, and a couple of my colleagues have studied actually melatonin, and there are some there's some metabolism of melatonin issues that have been described, some altered metabolites of melatonin that have been suggested by certain authors. But the question that ultimately is needs to be asked and addressed is, what is the primary driver of sleep problems in kids on the spectrum? And that's, believe it or not, in 2016, that's a hard question to answer definitively. There's some people who think it's a circadian rhythm issue, meaning to say a sleep clock issue, and some people have said that, for some reason, more children than not who are on the spectrum, their nighttime is almost an extension of their daytime. They don't seem the least bit sleepy. They have no interest in going to sleep, and it tends to look more like a sleep clock issue. Other people have suggested, no, that it's really what's the driving force is that these children, by virtue of the fact that it's hard for them to verbalize, that they are anxious, and and that anxiety is playing an extreme role here, and they can't express that. And so there have been some recent studies, and some relatively interesting ones, that have looked at anxiety medications to help children improve their sleep, and sometimes it has worked. And one particular study over the last 6 months looked at buspirone. Buspirone is an anti-anxiety medication. Its primary one of its only usages in medicine is as an anti-anxiety agent, and they've used it as a low dose in kids on the spectrum, and they found that the sleep has been helpful. So I'm not saying every child it helps every child, but it's the fact that it helped in a couple of the studies that I've looked at suggests, have also brought up the question, what is the primary driver of altered sleep in kids on the spectrum? And I think in part, some people, the camp is divided into folks who think maybe there's a sleep clock issue, maybe there's an anxiety issue in children who otherwise are pre-verbal or non-verbal, or there may be some occult issues that we would also not be able to glean in a medical sense, either like, for example, reflux symptoms, esophageal reflux, reflux esophagitis, or other conditions that we don't necessarily that are hard to glean because of the children's pre-verbal and non-verbal status.
Okay, great. A couple of the other products or supplements, I should say, that people are mentioning and asking about are GABA and magnesium. Have you seen any information on those or any?
Yes, absolutely. So GABA is interesting in a sense because GABA is short for gamma aminobutyric acid, and they are. It's an interesting. It's a neurochemical, a neurotransmitter that has been implicated in sleep, and I think I like the notion of GABA because if you use either GABA or some of its derivatives, there have been studies to suggest that it helps to promote deeper sleep in certain subset of individuals. GABA, for example, is a component of, for example, gabapentin, which is one of the agents that are out there commercially available to treat kids on the spectrum. It's also part of pregabalin, which is another agent. So some of these agents have been studied, not necessarily as children on the spectrum, but have been studied in the context. They both have been used in the context of treating epilepsy. And in the context of children who have epilepsy, they have actually done studies looking at sleep quality and the depth of sleep, and they found that utilizing some of these GABA medications have improved the depth of sleep. So if we look at those studies, for example, in both children and adults with epilepsy, mostly they actually looked at adults with epilepsy, but if they look at that as a sort of an example of a medication that has looked to improve the depth of sleep, I find that sometimes it's particularly helpful to use it in children who either have epilepsy or who are on the spectrum and who are looking for a deeper sleep pattern. And that's what I do for a living. Essentially that's what I do all day. I'm a pediatric clinical neurophysiologist. I look at squiggly lines on the brain all day and night. And so when I do that, if I have an agent that can help promote deep sleep and decrease the amount of awakenings at night, I'm sort of in favor of that medication. So that was my long-winded answer to say that I think GABA is probably something that is a helpful agent in a subset of children, and something that I often use to help promote sleep. I think it's a particularly safe medication. There are not a lot of, particularly if GABA is used in certain commercial formulations such as gabapentin and pregabalin. It does not have a lot of drug interactions. It seems to induce sleep. It even seems to maintain sleep. And they come both in a liquid form, which may be more palatable for some kids, and I think it's a particularly, and there's not a lot of interactions. I guess there's only an interaction sometimes, a modest interaction with certain reflux medications, but by and large it's relatively well tolerated. So that's something that is a possibility. The other medication that you mentioned was I'm trying to think of the other.
It was magnesium.
Magnesium. Yeah, magnesium. Yeah, some people have used magnesium. I am someone who some people have used magnesium in the context of it's been used in a lot of different things in clinical medicine. People have used magnesium in the context of migraine headaches. People have used magnesium in the context of restless legs and sometimes nighttime leg movements. So my only concern about magnesium is I'd like to just make sure that I'm using magnesium in a child who is in need of it. In other words, and I often will try to look at magnesium, serum magnesium levels, and if they're normal, I might not consider magnesium, only because you might say, is there a problem with too much magnesium? It's not that it's that much of a problem, but we know, for example, that magnesium can affect reflexes. We know the best example of that is in pregnant women, for example, who are on use magnesium sulfate, and their reflexes drop out when they're on them. So it's a medication I won't use unless I have clear indication that that serum magnesium levels are lower than normal. Now, if that's the case, then it makes perfect sense to use magnesium as a supplement, because and often low magnesium levels are tied in to alterations in calcium and phosphorus metabolism. So if I think that someone has low magnesium levels, I will also look at their calcium levels, sometimes their ionized calcium levels, and sometimes their phosphorus levels, because they often there may be something to suggest an underlying metabolic disturbance that might be causing sleep problems, and so that's sort of how I view magnesium supplements.
Okay, one last question on supplements. Somebody's asking about tryptophan with 5-HTP. Have you seen that used at all?
Yes, I have, and so it's interesting. 5-HTP has been used, was actually used for years and years. In fact, when I was first starting out as a sleep fellow at Massachusetts General Hospital in the early 90s, I was looking at a lot of research at that time over the previous decade, and believe it or not, tryptophan had been used, L-tryptophan had been used in comparative studies with other medications that we had at the time, things like, benzodiazepines and medications of that sort, things like diazepam and medications like that. And it turned out that in terms of helping sleep, it held its own in terms of comparative studies. The problem with it was not considered a medication, and it was considered a dietary supplement. And unfortunately, there was a bad batch of L-tryptophan that occurred I believe it was in the 80s or so, and it actually led to some deaths. And so, as a result of that, there was a condition known as eosinophilic myalgia, where children had, and adults actually as well, they had very pronounced muscle aches, and they actually had blood dyscrasias, and they actually died. Some of them had died, and so they took it. L-tryptophan was taken off the market for more than a decade. And whether fairly or unfairly, it was working for a lot of people. So I think it has now come back over the last, I would say, certainly for the last 5-10 years, is making a resurgence. And the notion is that they're looking at it. It's still considered a supplement, but I think there's more attention paid to the purity of the medication, of the supplement itself. And I think it may have. There haven't been a lot of direct comparative studies since it's come back out as a supplement again. So, but I think it does have promise, and it may have promise as a sleep agent, because it certainly had that years ago. And it's just that the issue with it was related to a small percentage of a poor and dire outcome that happened was what essentially was a bad batch of L-tryptophan.
Okay. This next question, I'm actually going to combine a couple of questions here. I've had quite a few people mention that they have a loved one who will only sleep either during the day or with a light on in their room. So, for example, this mother's describing a situation where her son sleeps with a lamp on, and if they try to turn it off, he immediately wakes up and turns it back on. If the power goes out, as soon as the power is back on, he turns it on. So can somebody get good sleep with full light?
That's a great question. I think that is a great question. I think that I'd love to see more studies looking at direct light and its effect on sleep. We know, for example, that as a general rule of thumb, light has been traditionally thought of as being antithetical to sleep. So for that reason, we've always, as sleep physicians, we've always suggested that you have your child sleep in a dark room, that the presence of even light, whether it's environmental light or as the sunlight is piercing through curtains, that impacts on sleep. But it's interesting, and so for that reason, more recent. We had, there's a big discussion in the lay press about using computer screens and the effects of the light from computer screens or from their iPads impacting children's sleep. So we are so the whole sleep medical field is has that bias that that light is antithetical to sleep. I have heard, however, that there are some children who can only sleep with the light on, and the question is it more of is it more of a behavioral response? In other words, they're used to having the light on, that when the light goes out, they become scared and more fearful, and they need the light on. So it's hard to say hard and fast rule. There haven't been a lot of actual sleep studies that looked on the effects of full bright light on sleep patterns. So, but it's hard. It would be hard. It sounds like it'd be hard for this particular child to easily switch to a more, if you will, more dark environment, unless there was, sometimes they use dimmer lights and sort of try to decrease the luminance of the lights itself over time. Some people have suggested that might be a helpful thing, but it's hard. It's hard to do, because it sounds like the child, at the very least, may be conditioned to sleeping with a bright light stimulus, and maybe the thought of being in darkness is just too fearful. So one has to sort of keep that in mind as well. It's hard to sleep when you're afraid, and and sometimes being in perfect darkness, that may make the children afraid. So I wish there were more studies that have looked on the effects of bright light on sleep, but unfortunately they're lacking.
Okay. This next question, it's a parent with an adult male, a son with autism, who sleeps very well at night, but at times during the day he'll become very sleepy. He'll fall asleep at work or in the car going home. If he's at home, he'll take naps, and on those days he will go to sleep very early, like 7 to 8 p.m. What might cause sudden onset sleepiness like that, just sort of out of the blue?
That's interesting. I think that it may be that I find in my practice that there's some, it's interesting. The one question I would ask is as to whether this is new for, I think it was a man, it was new for him versus something that had been going on for a while. I find that there are just some individuals who just need more sleep. It's if this is a new, but the concern is if this is a new process where a decent amount of night's sleep was associated with an improved level of alertness and attention during the daytime, and all of a sudden that has diminished where there's a need for more nap. I would just wonder about that particular issue. Is there any clear-cut causes of it? And so the things we look at, most notably, I look at sort of, if this is a new process, I'd like to see, for example, is there anything that the child, or it sounds like he's an adult now, anything that he's taking, he or she is taking that would impact on the quality of sleep? In other words, in terms of, there are lots of, this is a subject that's probably for even another hour, but there's a lot of things that, not only medications, but there's a lot of things that we take in the course of the daytime, whether decongestants and cough medicines, things that are typically over-the-counter that impact on sleep functioning. A lot of these medications have stimulants to them, and they impact sleep quality. And so I would just wonder if there's anything different to account for this change or need for increased sleep or a need for a nap during the daytime. The other thing is the sleep at night as good as it was. And so sometimes we think, oh yeah, my child's going to sleep, but are they waking up more? Is their sleep really as consolidated or continuous as it once was? And if the answer is no, then there may be some things that we need to look at in terms of the nighttime sleep. So it's hard to give, a reason as to why this is happening. It sounds, the suggestion is that this is a relatively new phenomena, and when someone is sleeping a certain amount of hours and is doing perfectly well during the daytime and not requiring a daytime nap, and all of a sudden they need a daytime nap, let's say of an hour or 2 hours duration as a regular thing, then I try to look into really, that would that would probably require some type of sleep evaluation, either what's going on in the daytime in terms of is there any cause for this, is there anything that he or she's taking that may impact on sleep functioning, either over the counter or any medications that might be at play here, or even the nighttime functioning. Is it just that he or she's not getting a good night's sleep at night, as good night sleep as he or she might be getting previously, and so that might be something that would be need to be looked at. That might be, if that is a new phenomena and it's persistent, I think that would warrant a formal sleep evaluation.
Okay. I've had a few questions about neurofeedback and its use in treating sleep. So do you know anything about its use in treatment?
Yes. So neurofeedback, I think, does have or may have a role. I think there are a lot of things that one can do to help, particularly help with folks getting to sleep. And so neurofeedback. And in general, biofeedback as a general rule has been very helpful in sleep. It's as a means of getting children back to sleep. I think sometimes it's almost the kids can sometimes use it as a game and sort of helps them to relax. And once again, this would suggest to me that sometimes it can be some sort of a calming mechanism. Sometimes the children regulate their sleep a little bit better and able to relax a little better and therefore initiate sleep. And somebody might suggest, well, does this mean that there's more of a behavioral cause of sleep difficulties in this context? It might be. It might suggest that. But I think that there are a lot of behavioral causes for difficulty sleeping in children on the spectrum, and so I think I'm for something like neurofeedback. I think it's certainly there's no downside that I can see with neurofeedback, and I think it may be helpful. Sometimes I think the children like it. They seem to enjoy it. They get used to it, and it seems to help a vast number of children who are on the spectrum try to get to sleep, usually in the beginning of the night. I think in the middle of the night, sometimes I have some children who use neurofeedback, but it's particularly helpful in the beginning of the night, I find.
I wanted to ask...
Oh, I'm sorry. Yeah.
Yeah, I'm here. I wanted to ask you next about the issue of sleep hygiene. This is something that we've talked about, I know, in other talks that you've done, and maybe you can address that symbiotic relationship between the family system and the environment and how that can impact positively or negatively the person who's having sleep issues.
That's right. That's a great question. I think sleep hygiene is an important issue. I think, for some, and just as a general rule of thumb, for a lot of us, sleep comes sort of as a natural issue. It comes. We don't often. A lot of us don't think about sleep. It just sort of happens, and we get ourselves in sort of an easy and relaxing and comfortable place, and we fall asleep. But for a vast majority of children on the spectrum, this is a hard process, and I think that a lot of times, and this once again speaks to behavioral management of sleep issues, and so I think that the whole notion of having a repertoire or almost having some rituals at nighttime to help on a regular basis get children ready for sleep is sometimes the only way that they can initiate sleep. And I think that's because, as I was suggesting before, there is something about kids on the spectrum with regards to their sleep pattern. There's a lot of children who just 8 o'clock at night is like 2 o'clock in the afternoon is like 11 o'clock in the morning. It's just they don't have the same social cues that it's getting dark, it's time to go to sleep, feeling sleepy. We all, most of us sort of get these cues. We're not even aware of that. Where nighttime occurs, we sort of, there's so many both behavioral and physiologic mechanisms that occur that get us ready to sleep. But for children on the spectrum, this is a difficult process. And we don't know the whys or wherefores in its entirety. We don't know whether it's because it's just a different wiring process, whether it has to do with, once again, melatonin issues and circadian rhythm issues, or whether kids are anxious when it becomes dark at night. Or maybe a combination of all of these things, but I like the idea of sleep hygiene. It becomes very important, and I think that includes, once again, for most children, being able to have somewhat of a repertoire or a ritual that where they able to go to sleep and get the feeling that. Well, this is sort of a repertoire that is going to get me to sleep on a regular basis, so that the children know that, hey, this is sleep time. Once I start, once I get read a story, or one time I look at a colored book, these things will help get me to sleep. And that I think is helpful, and I think even things like brushing teeth and washing hands and all these kinds of practices are very helpful when they occur in a rather structural format, particularly for children on the spectrum. And I think it helps them whereas the social cues are otherwise not as easily identified. And so I think it's I think with that, for most children, darkness is a sleeping in darkness for, I say, the vast majority of children, with that possible exception of the mother who asked earlier about sleeping in light. But by the vast majority, being in the dark, quiet place, getting ready for bed, making it somewhat of a ritual, a sort of a process whereby children feel comfortable going to sleep, I think makes a big difference. Knowing that the mother and father or caretaker are around and that they're there gives a feeling of comfort and warmth, to know that this is able, where the child's able to get to sleep in a calm and comfortable manner. I think sometimes the issues are I think what happens sometimes is that we, and this is sort of based on conditioning models, a lot of times children will get sleepy. They'll be in the living room. They will fall asleep where the light is on. They'll be maybe on the sofa. They'll fall asleep, and the parents will be there. Their brothers and sisters will be there. Sometimes then they're put in bed, and they wake up in an environment that's vastly different. They wake up in an environment where it's dark, nobody's around, they're alone. And so I think it's scary for a lot of children. So just sometimes to bear that in mind is that it's something that the children will say, will often fall asleep in an environment which they're accustomed to. So I think that sometimes is a factor as well, trying to make, there's an aspect with regards to sleep hygiene where it's somewhat monotonous, it's somewhat regimented, and somewhat rote, but I think it's helpful that way, particularly in children who have a hard time getting to sleep on their own.
Okay, great. That's really helpful. Hey, one thing we haven't touched on yet, and I think we should squeeze it in before the end, is the topic of parent sleep deprivation. So the sleep issues that the loved ones have also impact other people in the family, and most particularly the caregivers and parents. Do you have insight or just thought or experience about what kind of advice you can give those loved ones, and what, if you've heard any strategies they've used to try to keep the home going well even under those conditions?
I think that's a great question, and I'm glad you brought it up, because I think it's something that is very much particular to families of children on the spectrum. I think it's one thing for folks having trouble, let's say, wake up in the middle of the night, but it's quite a different additional problem to wake up in the middle of the night and knowing that if the child is up, the parents are up, and often the siblings are up, and the entire family is sleep deprived. The entire, and this is, so often we're talking about a very bleary-eyed child, bleary-eyed siblings, and bleary-eyed, very bleary-eyed parents. And so it's just, if I had a nickel for every parent who is up with their child all night long, and they're absolutely exhausted. And it really leads to so many problems by way of just even, they've done, sort of even issues about parental stress and how it impacts the ability to take care of children, both children on the spectrum and maybe children, there are other children who are not on the spectrum. It's just, it permeates the entire system. And I don't see a way necessarily, and so my heart bleeds for these parents, because it's hard to, there's just no middle ground. In other words, unless the children are sleeping well, I don't know how they really can actually get to sleep. Most parents of children on the spectrum will try to squeeze in sleep anywhere, any which way they can. Sometimes sort of in the morning, just a few hours, and just, and it's such a difficult process. So, and that in many ways is as hard a problem as any of it, because you're now dealing with, not only is the child sleep deprived, but the parents are notoriously sleep deprived, and they often, if they have busy families, sometimes it's very difficult for them to get in sleep. And I don't know of an easy way around it. But I think it's very particular to this kind of an issue, because it's one thing getting if you could, wake up in the middle of the night and just be in bed, but there's no guarantee that the children will be in bed, and they need to be cared for and tended to, and it's a big, big problem. So, but what it does suggest is that there's more of a need there's an additional need to get children sleeping at nighttime. And because it not only impacts the child's level of alertness and behavior and cognition during the next day, but also the parents. And you need parents who have a good night's sleep so that they can take care of children who are both on the spectrum and not. And it's a big, big issue. And I think it speaks for more of a need for individuals to get into the field of improving sleep with children on the spectrum. And I think we just need more folks who are willing to take this on, because it's a huge issue. And parental surveys have suggested up to 75-80% of kids on the spectrum have some type of sleep difficulties. That's a huge number when you can compare that to children who are not on the spectrum. It's somewhere around 10 to 30%. So it's really huge numbers of children who are on the spectrum who are not sleeping. So it's not only a medical issue, it's not only a behavioral issue. It's become almost like a public health issue, because you're dealing with a whole segment of our society. As the numbers of autism increases, some people say it's 1 in 46 or 1 in 48, and as these numbers increase, we're dealing with family members who are sleep deprived, and it's almost becoming a public health epidemic.